Hi everyone, my name is Maria Are. I'm working today with Muriel Kameni and Benson Tanjo. We are nurse anesthesia students. Our topic for our research is the placement and management of labor epidurals. So for this section of the presentation, we will be focusing on the anatomy and physiology of the spinal cord and the vertebrae. The objectives of our study involves the learner being able to describe the anatomy of the spinal cord, gain an understanding of the systematic changes in the body during pregnancy. We will align the drugs' respective dosing parameters of epidural anesthesia, as well as analgesia. We will discuss indications, contraindications, and complications of epidural anesthesia. We will also explain the procedure for epidural anesthesia. We will have two recordings. One will involve the placement of an epidural on a mannequin, and another will involve the placement of epidural on a live laboring patient. So the first slide talks about the anatomy of the spinal cord vertebrae. So the spinal cord is composed of vertebral bones and intervertebral disc. The goal of the spinal cord is to provide support, protection, and mobility. So looking at the picture on your right, we have the cervical vertebrae, which is composed of 7 vertebrae from C1 to C7. We have the thoracic vertebrae, composed of 12 vertebrae, T1 to T12, lumbar, 5 vertebrae, L1 to L5, sacrum, which is composed of 5 fused vertebrae, and your coccyx, which is composed of 4 fused vertebrae. In total, we have 33 vertebrae. And your spinal cord normally ends at L1 to L2 in roughly 90% of the population. And Muriel is going to be taking over from now on.
Hello everyone, I'm Muriel, and I'll be taking over this next section of the anatomy of the spinal cord. So over here we have the different layers of the spinal cord, and we have a picture next to it just to kind of go along with that. So initially, going through the different layers, you have the skin. Underneath, you have the subcutaneous tissue, the supraspinous ligament, interspinous ligament, ligamentum flavum, the epidural space, which is pretty much where you want to locate your epidural needle. And we have a picture right next to it, which is kind of showing you the epidural space and your landmark, where usually is around L3 to L4 or L4 to L5. Next, we have the dura mater, the subdural space, arachnoid mater, subarachnoid space, the pia mater, and the spinal cord. And going on to the next slide, we have the different curvature of the spinal cord. We have the primary concave, the primary one which concave anteriorly is composed of the thoracic and the sacral. As you can see on the picture, you have the thoracic area and the sacral, which both belong to the primary concave. And the secondary concave, which is posterior, is composed of the cervical and the lumbar, as you can see on the picture. And we also have an example of the different abnormal curvature, because some patients who come in the hospital sometimes with those different abnormalities. So with the scoliosis, you can see the abnormality which goes all along the spinal cord, along the spine, and it's more like in the S-shaped form. And the kyphosis, usually patient will come with like a hump on the back, and the abnormality is more around the thoracic area. And the lordosis one, you will see the abnormality more around the lumbar area. So there are 3 main ligaments. We have the supraspinous ligament, and you can see it a little bit on the picture as well. It extends from T7 to the sacrum. It's a strong fibrous cord, and it runs along the spinous process, which you can also look at on the picture as well. The interspinous ligament is a thin membrane ligament, and it connects the inferior to the superior aspect of the spinous process. And finally, we have the ligamentum flavum, which is a tough wedge-shaped thickness in the midline. Usually it looks yellow, but the picture doesn't really look yellow right there. It connects the different lamina and it measures 3 to 5 millimeter at L2 to L3. So the spinal cord goes from the foramen magnum to L1, L2 in 90% of the adult, as it was mentioned earlier by Maria, and it ends in L3 in pediatrics, and it also terminates at the conus medullaris. When it comes to the blood supply to the spinal cord, we have three main arteries. We have the single anterior spinal artery, which supply about 2/3 of the blood supply to the spinal cord, as you can see on the picture. And we have a pair of posterior spinal artery as well, which account for 1/3 of the blood supply to the spinal cord. The major artery is the artery of the Adam-Kiewicz, which arise from the aorta and provide about the major blood supply to the anterior lower third of the spinal cord, usually mainly on the left side of the spinal cord, more like unilateral. The spinal canal contains fatty tissue and the venous plexus, and it has meninges which cover the spinal cord. Among those meninges, we have three main layers. We have the pia mater, as you can also see on the picture right there, which is the thinnest and is highly vascular and is the one that adhered directly to the spinal cord. We have the next one, the arachnoid mater, is pretty delicate and is non-vascular and it adheres to the dura mater. The dura mater, which is the thickest and the most outer layer out of all three of them. And the next slide will be taken over by Benson.
Hello, everybody. My name is Benson. I'm going to take on from here. And I will be starting with the dermatomes. And the dermatomes are those areas of the skin where the sensory nerves derive from a single spinal nerve root. So the nerve roots, when we give our epidural, we essentially want to block our nerve roots because those are areas where our sensory nerves are derived from. So there are specific areas along the spinal cord where we want to be sure that they are totally blocked during our epidural analgesia. And the first one is to be able to have an effective analgesia, we want to block the area between T10 to L1 dermatomes. With our low local anesthetic concentration, this dermatome is going to be blocked and that's going to take care of labor pain. If as well, we want during the second stage of labor, the block should be extended to include the pudendal nerves, which is at the level of S2 to S4 dermatomes because of pain due to the distension of the vagina and the perineal pressure. Or sometimes the woman sustains like perineal tears or cervical tears, and we are doing a type of a suturing, we can equally be blocked. We are going to be interested to block these dermatomes as well. These slides kind of paint an image of where exactly these dermatomes arise from. For instance, as I earlier said, between T10, you can see it's at the level of your navel. If we block, when we're asking a patient, for instance, do you feel pain, or we are putting pressure up to the navel level, we are testing for a T10 block. If we pinch maybe the legs of the patient, we are looking for dermatomes around L2, L3, or even L1 up to about L3 blockages. And then if we are doing something at the level of the perineum or vaginal tears, we are looking at S2 and S3 dermatomes, which we expect them to be blocked when we give our local anesthetic agent. And in our next slide, we are going to be talking about these peripheral nerves. As I said, most of the pain, the impulses, the pain impulses, they arise from the level of our spinal nerve roots. And these spinal nerve roots, in a way, carry certain fibers. And these fibers are our A fibers, our B fibers, and our C. And they are either myelinated or unmyelinated, and they are either large or small. So for instance, the A and B fibers are myelinated. When I say myelinated, it means that if you look at the structure of a neuron, you have those myelin sheets, and between the myelin sheets, you have the nodes of Ranvier, which means that those fatty layers that runs from one node of Ranvier to the other is exactly what we mean by our myelination. And some of them are unmyelinated, like the C fibers. But the A delta and unmyelinated C fibers are blocked with similar concentration of local anesthetic agents. So when we give our label epidural, we are using a concentration that's going to block our A delta and our unmyelinated C fibers. Those ones are going to be blocked with that concentration of local anesthetic agent that we are using. The preganglionic B fibers are more readily blocked by local anesthetic than any fiber. However, in epidural, they are going to be blocked at a particular level. It's not going to be as dense or as intense as what we will see when we give, for instance, a spinal. The reason being here that these fibers are the first to be blocked, because when we give a spinal, we are depositing our local anesthetic agent directly on those nerve roots. In epidural, we are depositing our local anesthetic agents in the epidural space, and it takes time for that diffusion to take place as well. Again, these fibers are going to be blocked in epidural, but it's not going to be as so dense as when we do a spinal. So in our label epidural, you will not have a very heavy drop in blood pressure like what you will see, for instance, when you give a spinal. So it's going to be a block, but it's going to be kind of not as heavy as the other what we will see when we give, for instance, a spinal. In our next slide, for instance, we are going to see that small fibers, small diameter nerves are more easily blocked than large diameter nerves. And that the ones that are more myelinated and small are going to be blocked before the ones that are unmyelinated and larger. So why preganglionic nerves are blocked before the smaller unmyelinated C fibers in spinal anesthesia? Just exactly what I was trying to explain there. And that the nerves that then we are going to equally talk about the frequency of firing. Nerves that fires frequently are preferentially blocked over nerves that fire infrequently, which therefore means that, for instance, our pained nerves are those ones that fire more frequently. Those ones are going to be blocked faster. So our A delta, for instance, are the ones that actually fire more than our A alpha or our L gamma. For instance, those ones fire infrequently. And in our next slide, this table kind of gives a summary of what it takes to block the different fibers that are involved in pain, in temperature, in proprioception, based on the degree of myelination, based on what function exactly, like what muscles or what nerves they innervate, and the diameter, how large they are, and the speed or the frequency at which they fires. So if you look at the first part, which is our A alpha, our A alpha are highly myelinated, and they innervate the skeletal muscles, mostly the motor proprioception, motor and the proprioceptions. Proprioception exactly is like pressure control. Like if you're able, somebody asks you, can you feel your food? You know exactly where you are, and all of those things. Those are the nerves that control your proprioception. And those ones have a diameter of about 12 to 20. That's your head. That's kind of large diameters. And they fire, their speed of, their velocity is pretty high. So, and their blockages is like delayed. This is because they are kind of large. Because of those large diameter, these ones are going to be blocked a little bit later than when you deal with the ones that are less myelinated and smaller in diameter. Your B beta, exactly, again, they are heavy, and they are not as big as your A alpha. Look at the diameter there, it's 5 to 20 compared to 12 to 20. So they are a little bit smaller in diameter. Your gamma fibers, your A gammas, they control the skeletal muscle tone, but their diameter is just 3 to 4, yeah, 3 to 6. Even though these ones, as you see here, for instance, The A gamma are the ones that actually controls, they are very heavy. But the difference here with the gamma is that their degree of myelination are very, very less. They are less myelinated. And because of that less myelination, these A gammas are going to be the one to be blocked. So for instance, when you don't see, when the woman tells you, for instance, I can feel my leg, I can lift my leg up, it is because it takes time to completely deal with your gamma fibers. And those gamma fibers, as I said, they are less and less myelinated. But your D delta, for instance, are the one that controls your pain, they control temperature, they control touch. And those ones are the ones that are easily blocked. So when we give our labor epidural, exactly we want to deal with these three fibers: fast pain, temperature, and touch, by blocking our D delta, our A delta, for instance, sorry. Then our preganglionic autonomic nerves, those are the one that we block the B fibers. Again, the B fibers, when you block these ones with epidurals, you don't see so much drop in blood pressure, because these are the one that controls your blood pressure, the caliber of your blood, the caliber of your blood vessels. But when you give a spinal, for instance, we are going to have a very more blockage of these B fibers than what we see when we give our labor epidural. And part of it is because of the concentration of the local anesthetic agent that we are using. And then the last and not the least is our C fibers. The C fibers as well controls the sympathetic, which is at the level of your postganglionic. So this ones as well is going to be blocked like second after you deal with the preganglionic. You might block this one, you might see this one at a later time, but it's not as fast as when you block your B fibers. And then your dorsal roots. The dorsal roots here are like your afferent nerves. So they carry impulses from your skin to their spinal cord. And that dorsal root, for instance, carries sensation for pain, for temperature, and touch. So when you block your dorsal root, you are going to be blocking those three fibers that controls those three functions. But equally have your ventral roots. Your ventral roots are the roots that supply the anterior part of your spinal cord, and those anterior part of your spinal cord carries your motor nerves. So your ventral roots are going to be blocked later on down the line, and that is why it takes time, because in the control, your ventral controls your motor nerves, your motor nerves. It takes time to block those one. So we therefore means that when we give our local anesthetic agent, they very much block the ventral roots, because we want to take away that sharp pain. We want the pain, and that's why the vasodilatation that you feel when you block your dorsal roots, you see that the patient is going to feel like sometimes they lose sensation to temperature. They might not be able to feel their touch because of the vasodilation and the loss in heat that you create with your local anesthetic agent by blocking your dorsal roots. In our next slide, this kind of just concludes the things that I've been talking about. You block, in terms of which one comes first, you block your B fibers, you block your C and your A delta fibers, which are the ones that controls pain, they control temperature, they control proprioception. And then the last one to be blocked are your A gammas and the A betas and A alpha fibers. And that ends, this slide kind of ends this first part of the presentation on anatomy of the spinal cord. And as usual, if you have any concerns or any questions, you can drop them under the comment section of the YouTube video, or you can just email, drop a comment in our WhatsApp forum. Thank you so much again for taking all your time to be part of these studies, and we hope that we're going to take it to the very end together. Thank you.